Good day, dear students. Today's lecture is about the principles of proper, safe, and appropriate prescription of drugs in the elderly. So the intended objectives of this lecture is that one should be able to describe the age-related changes that affect pharmacokinetic properties of medications. One should know the age-associated changes in pharmacokinetics, which includes drug absorption, distribution, metabolism, and excretion, the pharmacodynamics, risk factors for drug interactions. Also, one should be able to describe the concept of polypharmacy, learn the practice of safe prescribing in older adults, taking into account the different physiology, drug interactions, and multiple pathologies. Recognize the role of non-pharmacological alternatives. Recognize adverse drug effects and describe the common presentation of adverse drug reactions in the elderly, including adverse drug and drug disease interactions. And finally, one should be able to describe the principles of proper and safe drug prescribing in the elderly. So why do the elderly represent a therapeutic challenge? Well, for a number of reasons. In the elderly, there is usually impaired physiological reserve. A very nice term to use is homeostasis, which comes from homeostasis. So our physiological reserves decline as we get older. Also in the elderly, they usually have multiple disease. For example, an elderly patient has type 2 diabetes together with hypertension, ischemic heart disease, knee osteoarthritis, and all this requires multiple drug use. Also in the elderly, there is atypical or non-specific or even hidden cryptic presentation. The best example I can give you is urinary tract infections, which is a very important issue in elderly patients, especially elderly females, where instead of presenting in the typical manner as in young adults with dysuria and fever, the initial presentation may be in the ER, where they come in an acute confusional state, what is termed as delirium. In the elderly, there is also rapid deterioration if they are not treated quickly due to age-associated loss of adaptability, and there is a high incidence of complications both due to disease itself and due to treatment. In the elderly, changes occur in the pharmacokinetics, which is everything that has to do with the absorption, distribution, metabolism, and clearance of drugs. From the aspect of absorption, practically not much happens. There's not a significant change. Only when we are talking about tube feedings and that do we notice a reduction in absorption, if it is continuous. However, significant changes occur in the elderly in distribution of the drugs. This is due to the fact that a number of physiological metabolical changes occur with aging. Number one is that we have a decrease in the muscle mass with aging, a phenomenon known as sarcopenia. In addition, we have a decrease in the total body water content with aging. So if water makes up 70% of a young adult's body weight, by age 70-75, we're down to 70-65%. Also, there are some other physiological changes, such as a decrease in thirst sensation with aging, that will affect, and that is why the elderly are more liable to get dehydration. In addition, we have a decrease in the bone mass with aging. On the other hand, we have an increase in the total fat composition with aging. So all these changes will affect drug distribution. So low serum albumin will result in changing of the free versus the bound proportion of drugs. The increased fat will increase the half-life of lipophilic drugs such as diazepam and anesthetics. The decreased body water, and that probably is the most important change, will lead to lower volume of distribution in polar drugs. And the decreased muscle mass is also important. The drug, as you know, the kidney function declines with age. So lower glomerular filtration rate is due to the fact that we have a decrease in the glomeruli, in the size, as well as a decrease in the tubular secretion and a reduction in renal blood flow. So serum creatinine is thus not a reliable measure of renal function tests in the elderly, because you know the creatinine is due to muscle breakdown. So as we said, with age there is a decrease in the muscle mass, and therefore there might be significant renal impairment, and this is not shown in the serum creatinine level. It might be normal or slightly reduced. So therefore we use the creatine clearance is a better renal function test to do in the elderly. And it can be calculated by this equation, which is known as the Cockcroft-Gault equation, where creatinine clearance equals 140 minus age, say 70 times the body weight, say 70 kilograms. So that is 4,900 divided by 72 times the serum creatinine, and that is a value that we have for men. For women, you multiply this ratio by 0.85. Also in drug, there are changes in drug metabolism, reduced liver function due to decreased liver size, blood flow, and due to disease such as congestive heart failure, causes changes in drug metabolism. Phase 1, first pass oxidative reduction activities are reduced. So this is particularly important when we're talking about drugs such as propranolol. Phase 2, drugs are preferred. In general, biotransforming enzymes are reduced in the elderly, and of course the commonest biotransforming enzyme that you probably know is the cytochrome P450. This graph shows very nicely the decline in kidney function with age. So beware of drugs with predominant renal elimination, such as the aminoglycosides, the antimycotics, such as fluconazole, antivirals, which are commonly used in the elderly, especially immune-compromised elderly during the winter months, for diabetics that have herpes zoster, so we use acyclovir, ribavirin, beta blockers such as atenolol, beta-lactam, antibiotics such as penicillins and cephalosporins, digoxin, H2 blockers, and lethalin. So to summarize the alterations in pharmacokinetics in geriatric patients, we said absorption is more or less unchanged. There is significant changes in bioavailability, the volume of distribution, and elimination. Now, there are also important age-related changes in drug sensitivity, drug receptor interactions, drug-drug interactions. So there is altered pharmacodynamics with aging. Aging is usually associated with an increased sensitivity for many compounds, such as opiates. So we have to be careful with such drugs. And on the other hand, we have decreased beta-adrenergic responses in the elderly. Therefore, it is not wise to use a beta blocker to treat hypertension in the elderly. The alterations in pharmacodynamics can be complex and are usually poorly studied. Generally, we find the elderly are more sensitive to drug effects, for example, blood-brain barrier and anticholinergics and benzodiazepines. We have to be careful of these drugs in particular. We'll talk about this later on. So, the pharmacodynamic alterations in geriatric patients, the main organs that you should take care of is the urinary bladder, where anticholinergics can cause urinary retention, particularly in elderly men with benign prostatic hyperplasia. On the eye, anticholinergics can lead to disturbed accommodation or even acute glaucoma. On CNS, benzodiazepines, opiates cause sedation, and that's why we don't like to use these drugs, particularly in the elderly, because of the sedative effect and because they cause patients to be drowsy, etc., and can cause patients to fall and have fractures. Beta blockers, digoxin, also have CNS side effects such as depression, blood pressure regulation, careful of ACE inhibitors, neuroleptics that can cause hypotonia. The kidney in particular we should take care of, particularly when using non-steroidal anti-inflammatory drugs, because they can cause even renal failure in the elderly. The heart, be careful, and lungs, be careful with sympathomimetics and beta blockers because of reduced. So if we had to look at the reasons for side effects of drugs in geriatric patients, it is multifactorial, as you see. So we have decided there is decreased organ function, decreased homeostatic functions with aging, changed pharmacodynamics, changed drug concentrations. Polymorbidity is usually present, requiring polypharmacy. And we also have the issue of decreased adherence and compliance in the elderly. And that's why we try to use the minimum of drugs in the elderly, because they usually do not tolerate them and they do not like taking too many drugs. All these will lead to side effects. So adverse effects, particularly related to drugs, are very common in the elderly. So much so that, so as not to miss an adverse effect presenting as a symptom, we say any symptom in an elderly patient should be considered a drug side effect until proved otherwise. The rate of adverse drug events requiring an ER visit for persons 65 and over is more than twice the rate of persons under age 65. The rate of adverse drug events requiring hospitalization is nearly 7 times greater for persons age 65 and above compared to those 65. We also nowadays speak of inappropriate drug use. So what do we mean by inappropriate drugs? For example, using antibiotics, antibacterials to treat a viral infection. We in geriatric medicine tend to go by 2 lists. The Beers criteria, which is a list put by expert consensus in the USA, where they have a whole list of medications which are considered potentially inappropriate for older adults based on risk versus benefit. And we can always look up these drugs in this list. On the other side of the Atlantic, in Europe, we also go by what we call the stop and the start criteria. So the principles of drug use. We, first of all, have to ask ourselves, is treatment warranted in the first place? For example, elderly patients commonly complain of constipation. So before jumping into giving laxatives, look at the causes of constipation in the elderly. It's commonly due to the fact that they have decreased thirst sensation, so they do not drink enough water, they do not have teeth, they do not eat roughage, they do not move enough, so there is inactivity. All these lead to constipation. So if we advise them to drink more water, more roughage, walk about a bit, exercise more, then we have treated them in a non-pharmacological way. In other words, we always ask ourselves, are non-pharmacological alternatives available? Because remember, we want to use the least number of drugs, and we would be very happy if we didn't have to use drugs in the first place. Always consider risk versus benefit of drug therapy and establish goals of therapy. Consider the whole person, not just one disease or one drug. So the rational drug prescribing in the involves that we determine whether there is underuse, overuse, or misuse is a problem. We always prescribe the most effective drug. We minimize side effects and the risk of iatrogenic harm, maximize compliance and adherence, and very importantly, particularly in our country, we conserve resources through intelligent prescribing. We have been talking about for many decades about polypharmacy being a major problem and issue in geriatric medicine, where we define polypharmacy as the concurrent use of many medications in an elderly person. And by many, we mean 5 or more medications simultaneously. Sometimes, however, we are obliged to use these drugs because, as you have seen, the elderly usually have multiple conditions. So perhaps we should now concentrate more on appropriate drug prescription, the appropriateness of using drugs, the potential benefit where the potential benefit outweighs the potential risk. So that is slightly different. So for rational prescription, we said, first of all, we have to determine if a drug is needed at all. Indeed, we should always review all the drugs that the individual is on at each visit. And our main aim always is to cut down on the number of drugs, and if we can stop using a drug, we are always very happy to do so. So if a drug is in fact needed, we assess the patient for frailty and comorbidities, we review prior and current medication use, and we assess the patient's ability to comply with directives. It's no use just prescribing a drug to an elderly patient. Make sure that he understands how to take it, when to take it, and that he remembers when to take it. So if the patient is not able to take the medication himself, we educate the caregivers. We always pick a drug and dose based on our knowledge of the patient and the drug. We can use explicit criteria, software, lists, like the Beers criteria list that I just spoke about. Other tools to evaluate choices, drug interactions, drug disease interactions. And it's always very wise to, when uncertain, to consult a knowledgeable pharmacist. Explain drug use to the patient or caregiver. Monitor for effectiveness and side effects, and always reevaluate the need for ongoing therapy. So once more, the recommendations for pharmacotherapy in geriatric patients is we always ask ourselves, is pharmacotherapy necessary? There should be a clear diagnosis, and we always consider non-pharmacological possibilities. Well-documented pharmacotherapy, avoid new drugs and drugs with long lives. Avoid polypharmacy. Start low and go slow. We always start with the smallest dose of the drug in elderly patients, and we slowly increase. What do we mean by slowly? From 10 to 14 days. Consider unusual side effects. So I'm giving a diuretic for my elderly patient who has systolic hypertension. After a couple of weeks, he comes back with incontinence. He complains of incontinence. That's the symptom. So instead of treating the symptom by giving him an anticholinergic to stop the incontinence, which I would in this way make matters worse, I should take a good history and perhaps remove the diuretic, which can be the cause of incontinence, and the problem will be solved. So be careful of adverse drug events presenting as symptoms. Always answer the following questions. Can a drug be stopped? That is, can I prune the drug regimen? What is known as deprescribing. Does the patient understand the therapy? Is the patient able to follow the therapy? So the principles for prescribing an older person include starting on a low dose, considering risks versus benefits, considering pre-existing medical conditions. For example, when you have arthritis medications to prescribe and we have kidney disease. Consider risk of drug interactions. Watch out for anticoagulants such as warfarin. Use as few drugs as possible. Always economize. For example, you have an elderly patient with type 2 diabetes and diabetic nephropathy and hypertension. So instead of giving a calcium channel blocker for the hypertension and an ACE or an ARB for the diabetic nephropathy, perhaps you can just use an ACE or an ARB to treat both conditions. Consider dosage requirements, which should be decreased in renal impairment. Beware always of the kidney, and know that the renal function decreases with age. Consider the effects of quality of life. Use familiar agents. You don't have to know all the drugs. Just know a few drugs from each class and know them well. Know the drug-drug interactions, drug-disease interactions, and use those. And always, particularly in our country, we should consider the financial impact. Try and obtain a drug-free interval wherever you can, especially when you have an elderly patient with chronic heart disease and he is on statin perhaps for life. Every now and then, give him a drug holiday, a statin holiday for about 2 or 3 weeks, and make up for it by telling him to avoid fatty foods. Define outcomes of therapy. Consider non-pharmacological therapies. Listen to your patient. Some of the high-risk drugs that you should avoid in the elderly are the anticoagulants such as warfarin, digoxin, clopidogrel, antihistamines, non-steroidal anti-inflammatory drugs, and corticosteroids. In summary, for elderly patients, obtain a complete medication history, review medications regularly and before prescribing a new medication, know the actions, adverse events, and toxicity profiles of prescribed medications, start long-term medications at a low dose, and titrate the dose on the basis of tolerability and response. Attempt to reach a therapeutic dose before switching or adding another medication. Educate patient and/or caregiver about each medication. Avoid using one medication to treat the adverse events caused by another. Attempt to use one medication to treat 2 or more conditions. Avoid using drugs from the same class or with similar actions. Communicate with other prescribers. Be knowledgeable about the medication's dose, adverse events, interactions, and monitoring. Write out the directions, strength, route, quantity, and number of refills. Start low, go slow, but get to therapeutic levels, and sometimes say no.